Sit at like 6.5 on most of them. If you refinance it, is it? It's broken.
His wife planned a big birthday celebration.
I gotta make sure what I'm doing first. Yeah, I didn't refinance my car.
And in retrospect, that was good timing. Joe's been around after that. To be able to be appreciated by all of his friends while he was still growing.
We should probably.
That's what he said.
I did look at the
Good here?
Go for it, yeah.
Okay. Hopefully, we're all online as well, so there's more people out there. It's my privilege to have been involved with the Dodge Lecture Series for quite a number of years, and to be able to introduce the Dodge Lectures when they come and meet them. These are people who are, you know, the best of the best. And it's an honor for us to have them here. It's an honor, and it's in memory of Dr. Dodge's honor, who was at St. Luke's, I think since the 60s. This is the 46th, I believe, Dodge Lecture. And if you pick up one of the little brochures, in the middle you will see a list of the Dodge Lectures, and although you may not recognize all the names, I will tell you it's basically a who's. A large number of the people in this list have written the textbooks that we've all come to know, love, and hate. So, you know, we get to add another person to this established list, and it's my honor to introduce Dr. Watts. He currently serves as the Director of Osteoporosis and Bone Health Services for Mercy Health in Cincinnati, Ohio. I will not read you his CV because it's literally this thick, and he's had a long career in osteoporosis at Emory, and most recently now is at the University of Cincinnati. He has served as the president of the American College of Endocrinology, president of the International Society of Clinical Densitometry, chair of the FDA's Advisory Committee for Endocrine and Metabolic Drugs, although not while I was on it. We didn't cross there. And don't give him a hard time for this. On the ABIM subspecialty board in endocrinology and metabolism, one of our favorite things is taking boards, right? He's active in multiple professional organizations, serves on the editorial boards of numerous journals. Again, his CV has publications, book chapters, abstracts, articles throughout, and in prestigious journals. We had a very good talk last night, and he is going to talk to us today and then be at KU tomorrow, and St. Luke's tomorrow. He was at KU yesterday. All of those should also be on Zoom, so if you want to listen to another one, it should be available to you. And it's my pleasure to introduce Dr. Watts for the Dodge Lecture. Thank you for coming.
Thank you for the introduction and for the welcome. I'm an endocrinologist by training. Started my career in private practice in the hometown I grew up in, Asheville, North Carolina. Was the first and for 5 years the only endocrinologist. Added to the practice and then moved to Emory University in Atlanta, where I was on faculty for almost 20 years, happily taking care of patients with diabetes, thyroid disease, more challenging and less common endocrine problems, but always had an interest in bone. And in the 1980s, bone densitometry came along, interest in drugs that might have an effect on the skeleton. I was involved in one of the first clinical trials for osteoporosis that wound up being a lead article in the New England Journal of Medicine, and that opened the door to much of what we'll be talking about today in terms of the things we have to use. And osteoporosis crowded out the other things in endocrinology. I couldn't keep up with diabetes, thyroid in the depth that I wanted and still do what I needed to do in the bone area. So my friends say I became a bonehead. That's
Thank you,
okay. Osteoporosis, as
Can you
you
guys
might
unmute
guess, is
at
more common
Truman so we
in
can hear
women
you?
than men.
Oh. We're on mute.
We're on mute. All
Thank
right.
you, guys.
Unmute. Got it. Okay. Well, I won't repeat any of that. At the University of Cincinnati, before COVID and when there were still free lunches for everyone, attendance at noon grand rounds was pretty good, and we had an outside speaker on breast cancer. A lot of interest. 50-minute talk, a lot of questions and answers. Nobody moved until it was over. The next month, we had another free lunch. We had another good lecture on prostate cancer. And at the end of the lecture, when it was open for questions, all the women got up and left. Still don't understand exactly why that happened. So I hope that you will be somewhat interested in osteoporosis in men. Let's see if I can make this go. It's at least hit the cartoonist. Joe, is that you? I haven't seen you since you were this tall. I was the chair of an Endocrine Society task force to create guidelines for osteoporosis in men. This was 2012. They keep asking, is there anything new that we need to update? And there are a few minor things, but most everything that I'm going to tell you today is what our group agreed on 10 years ago and sort of leads us ahead. So I want to talk to you about the importance of forearm fractures. In a moment, you'll understand why I single that out, and possibly rib fractures as risk factors for osteoporosis in men. When we calculate T-scores, what's the database we should use? Should we compare men with men, or do we compare women with women? Do we compare men with women? And there is a fracture risk calculator called FRAX. And for women, the T-scores work pretty well to tell you who needs attention, who doesn't. In men, they don't work as well, and so that extra step with the fracture risk calculator is needed. Testosterone is something to think about if testosterone levels are low, and this was probably the most contentious issue in our task force group as to whether or not we should even measure testosterone as part of the evaluation of men with osteoporosis, whether we should ever offer treatment with testosterone to reduce fracture risk. We do have a new drug that was approved just 11 months ago. Abaloperitide is a PTH-RP analog and an anabolic agent that adds to the list that I've had to share with you up till now. When I'm giving a talk, it's nice to have some kind of eye candy illustration to go with it to sort of keep you occupied while you read this list of words. I will warn you that if you go on the internet and type in pictures of older men, you don't want to go there. So I've decided to back off and do retirement communities. So the pictures that you'll see added in here came from safer places than they might have. So how are men different from women? And this is a short list. There's a whole lot of other differences that I'm sure are important. At peak, which is around 20 to 25 years old, men have higher bone density. In part, that's an artifact of the way we measure bone density with dual energy X-ray absorptiometry. It overestimates the density of larger bones, underrates the density of smaller bones. And men do, on average, have larger bones, different geometry, and all those things sort of work out to the best in the way bone density works. Have greater muscle mass and less likely to fall. No universal equivalent to menopause. and a shorter lifespan. So if you have your MI at 67, you don't have your hip fracture at 72. Lifetime risk for any clinical fracture is about 50% in women and about 30% in men. So at age 50, in their remaining lifetime, 1 out of 3 men will experience an osteoporosis-related fracture. I haven't updated the cost, but it goes up each year. And it's not just the cost of taking care of the fracture, but many post-fracture years are spent in extended nursing home care. On the left of this slide, you can see that in the younger ages, there are more fractures in men than there are in women, boys than girls. And I think that has to do with trends in physical activity. Men are more likely to bang up against one another or walls or other hard things, women less likely. But it's after about age 50 that you see a spread in the other direction, that the risk of fracture goes up in both men and women. But it grows up more steeply and earlier in women. So you might think, well, we don't really have to worry too much about osteoporosis in men until they're in their 70s or 80s. But I have male patients in my practice who are in their 30s. 2 came within the same month, both policemen, not knowing one another, but in separate taser demonstrations were volunteered to be victims. And the muscle contraction from the taser created vertebral fractures, and a bone density test show they're -4, with no apparent underlying cause that we could pinpoint for something like that. So osteoporosis can occur at any age, in any sex or gender, and in any racial or ethnic group. These are data on fracture risk, women and white men in yellow, and you can see hip fractures go up in both, but for men about 5 to 10 years after the steepness of the curve in women. Spine fractures go up a little bit younger, and again, similar for men and women, just men pushed out to the side. And I mentioned forearm fractures early to call your attention to them and show you here that there is no increase in forearm fractures in men with age. I was invited to the University of Alabama, Birmingham to be part of a brainstorming group. We looked at a series of scenarios and what would you worry about and what would you be less concerned about. And as I ranked things the first time, there was an older black man who'd had a wrist fracture. And I said, well, I wouldn't worry too much about that. But on further reflection, that's unusual. And that really should get your attention, not to say it's infrequent, okay. Then infrequent things are often the important thing. So don't ignore the possibility if a man shows up in your clinic with a cast on the arm and say, we better look for how you're doing at other skeletal sites. Mortality after fractures is actually higher in men than it is in women. So you'll see after a hip fracture almost double the mortality for men versus women. Why? Because men typically fracture when they're older. They have more comorbid conditions. So it's more compelling there to try to avoid the fracture so that it doesn't add on to the other burdens that health has brought to the men that get to that age range. So we can have a bone density test. Who should have it? And the U.S. Preventive Services Task Force issues evidence-based recommendations. They're the ones who recently said you should have your first mammogram if you're a woman at age 45 because we're seeing breast cancer earlier now than we used to. And they've said for women, age 65 is cost-effective to test and treat for osteoporosis. They're not sure about men. But from what I've shown you, it's sort of logical to think if 65 is the right age for women, then 70, somewhere in there, 75 would be the right age for men. And higher risk patients, men and women, should be tested sooner. Guidelines have to be simple to work, so if we say for women 65, what about the woman who has menopause at 30? 65 is 15 years after the usual age at menopause, so a woman who has menopause at 30, it would be logical to test not at 65, but at 55. And so there's a long list of diseases, conditions, medications, family history that may be associated with higher risk of fracture, and those would be reasons to test sooner rather than later. You don't have to have a bone density test to get a prescription for the medications we'll be talking about, but it's useful to have a baseline and some idea about severity, and so getting a test either to make that decision or to have a starting point to monitor treatment would be advisable. How well are we doing? Not very well for women. That's the red line here at the top, 10 to 14% over the course of 2002 to 2016, and dismal for men. So I was working with a primary care physician and some others on a slide set about bone health and osteoporosis, sponsored by the American Society for Bone and Mineral Research, to be used for primary care doctors. And this primary care physician told us she just met with her practice manager and reviewed her 400 most common ICD, then ICD-9 codes. And osteoporosis was not in the top 100. So in a primary care setting, if you're talking about mammograms, colonoscopy, shingle shots, RSV, seat belts, where do you find time in that 15 minutes to talk about osteoporosis, bone health? So it is covered by Medicare, 1998. You may not know that when Medicare was started in 1964, that the enabling legislation prohibited Medicare dollars from being spent for screening or preventive services. So for Medicare to pay for mammograms takes an act of Congress. For Medicare to pay for colonoscopy, it takes an act of Congress. And for Medicare to pay for bone densitometry, it takes an act of Congress. Congress, kind of like the Postal Service, is not as reliable or productive as they used to be. And there's some loopholes here from 1998 in the Bone Mass Measurement Act that are pretty obvious to most people, but they've never fixed them. So Medicare will pay for bone density for an estrogen-deficient woman at clinical risk for osteoporosis, and they go on to say that a woman taking estrogen might still be estrogen deficiency. Got that covered. The bottom, they pay for monitoring. They promise every other year, and most carriers will pay yearly if we're monitoring treatment. Then in between, they say if you have a vertebral abnormality, that would be radiographic osteopenia or compression fracture, but they don't say hip fracture. They say if you're on long-term glucocorticoids, but they don't say androgen deprivation therapy or other drugs that might be bad for bones. They'll pay if you have hyperparathyroidism, but they don't list Cushing's disease or other problems that might be bad for bones. So if you're a man with Medicare, you have to have a vertebral abnormality, you have to be on steroids, or you have to have hyperparathyroidism for bone densitometry to be covered. And it gets worse. What man is going to go for a bone density test at the Women's Imaging Center? And that's where many institutions have their bone density tests, which is not an illogical place. Not necessarily when you start your mammograms do you get your bone density test, and not that you get the two every time together, but to have a man go through the barrier of under the pink ribbon and in a waiting room full of women is. Had a patient who wound up with multiple myeloma, 5 compression fractures, and had to go to a breast imaging center to get tested to find out where he was. So there are workarounds for almost everything. You don't get into medical school unless you're smart, and you probably don't get into medical school unless you're clever. And the people who put these regulations in place, I don't know if they have children, but certainly at my house, the teenagers, we had some restrictions. But once they proved that they were reliable and honest and fair, we lifted those restrictions. Unfortunately, the restrictions that get placed on medical care often stay in place. So that's where we are. The patient has back pain or height loss, and you want to get a bone density test that's covered, you can get an x-ray. That's covered. And if the x-ray shows osteopenia or a vertebral deformity, you've got a covered diagnosis. I'm not going to go into details about other ways of measuring bone density because there's nothing that substitutes for that, but there is a portable heel ultrasound device. and I visited a retirement community where they give that away to their men patients for free. And if they get a -1 or below, they have another diagnosis code that will get bone densitometry coverage. Otherwise, the patient's supposed to sign a waiver. So if you have a suspicion that a test won't be covered by Medicare, you're supposed to tell the patient, and the patient can say, I don't want the test, or I'll sign here and I'll pay for it. If they don't sign that, you can't bill them. So unless that's happening here for your male patients, there may be a reimbursement issue. And if you're somehow involved in that, there may be somebody tapping you on the shoulder and say, we've got to talk to you about a cash flow problem. Shouldn't be that difficult. What do we do with the results? We use the T-score, and that compares an individual's bone mineral density with the mean value for young normals and expresses the difference as a standard deviation score. In the spine, a standard deviation is about 10%. The hip, it's about 12, 13%. This committee in 1994 said if you're -1 or below, so this is a time of life when minus is okay, 15% below the average young person, we'll call that normal. 2.5 standard deviations low, 25% is osteoporosis. And in between, they called low bone mass parenthesis osteopenia. And in teaching densitometry interpretation, we say don't use this in patients before age 50 because the bell-shaped curve, which is the distribution for bone density, statistics tells you -1 or below in a healthy population, 17%. Yet fracture rates in young people are low, as I showed you, and we don't want to put a medical sounding label on a 25-year-old who has no reason to be concerned about that. The organizers of that meeting explained why they chose that. They said such a cutoff value identifies approximately 30% of postmenopausal women as having osteoporosis if you measure the spine, hip, or forearm. And that's approximately equivalent to the lifetime risk of fracture at those sites. Not quite. Lifetime fracture risk is 50%, but it gets there. This is Goldilocks, okay? Not too many, not too few, but just right. But that's for postmenopausal women. And they go on to say the same absolute bone mineral density after adjustment for the larger body size, they don't tell us how to do that, could be used for men. So here's the problem with this two-dimensional areal density. Density should be volumetric, grams per centimeter cubed, and we report grams per centimeter squared because it's a two-dimensional thing. And you can see that these two cylinders, which are different sizes, have exactly the same volumetric density, but have a lower areal density for the smaller bone. And this could be an issue for blacks versus whites, can be an issue for men versus women. It's an issue for children versus adults. The difference in bone density for men versus women in adulthood is largely due not to more density inside the bone, but the larger bone that's involved. If you use a male database, you're comparing with a higher standard and you get slightly lower T-scores, not much. At least in the hip, it's a minimal difference. In the spine, it's a full standard deviation. Problem in the spine is as we get older, we get calcium on the outside. And that makes the spine look better than it really is. And longitudinal studies show while in women, spine bone density goes down on average fairly steeply after about age 40 or 45, doesn't change that much in men. So even though there's this difference, it probably doesn't matter that much because for men, you're going to find lower values in the hip. There's some studies that suggest that men fracture at the same bone density as women. If that's true, then we need a female database for men, and some suggest that men fracture at a higher bone density, and if that's the case, then we ought to compare them with men. What's the answer? Well, until 10 years ago, and probably still today, all the bone density manufacturers, all two of them, use a male database to calculate T-scores for men. The online tool that I'll talk about in a minute, FRAX, the fracture risk calculation, does its own T-score calculation, and they use a female database to give you the T-score that they'll give you. So if you have a bone density printout done locally and you have FRAX with a T-score on the printout or on the screen, the T-scores are going to be different. And they'll be better on the printout than they are, they'll be better on the screen than they are on the printout. 2013, I was busy again. I was the chair of a task force for the International Society for Clinical Densitometry to resolve, among other things, this question of should we use a male database for men. And our group decided, yes, we should not use a male database for men, but we should use a non-race adjusted Caucasian female database for everybody. Part of the reason would be for women at any age, blacks have higher bone density than whites, have a lower age-adjusted fracture risk. And if we included race in the T-score calculation, we'd find the same prevalence of osteoporosis in every ethnic or racial group. That makes no sense. And the newer NHANES data, the population surveys in the US, show that today's young normal people have better bone density in the hip than the ones did in 1998, where the standards we were using at the time came from. So should we use the new standards instead of the old standards? And we said, well, if kids today are better, they would have a higher average IQ, but you wouldn't change the scale on the IQ test. And so we recommended sticking with the 1988 NHANES database and using the female Caucasian database for everyone. This is the newer data, and you can see that men tend to be higher than women, and that the racial or ethnic differences are fairly clear for hip. And again, this secular trend that hip has moved up from the solid line, which was 1988, to the one with the boxes, which is 10 years or so later. When you look at the spine, again, you see it goes down in women, but doesn't really change much in men. So your man who goes for a bone density test, they'll do a spine and hip, but it's almost certainly the hip that will be giving you the information that you want. Most people who have fractures due to osteoporosis don't meet the criterion for osteoporosis. Again, this is a bell-shaped curve, and while those near the middle have a lower risk of fracture than those at the tail end, there are a lot more of them. And so even though as a population the risk is lower, there are just numerically more fractures. So when you see men for hip fracture, only about 40% are minus 2.5 or below. Almost 60% are in that middle osteopenia range. So again, the message here is if you see a man who has a bone density test and their hip is between -1 and -2.5, you can't just stop there. You have to move on. So if you look again at that NHANES data and how many people had a -2.5 or below, at the hip using a female database, it's 4%. Using a male database, it's 6%. So if we switch from male to female, we're not losing a whole lot. But where would Goldilocks be with all this? We're looking at a lifetime risk of hip fracture, at least around 10%, and a lifetime risk of any fracture in the 25 to 30%. So Goldilocks wouldn't be happy with either 6% or 4%. So if you go through the FRAX calculation, and this is an older version, and you'd get fewer patients if you use the newer version, you'd find a few with a low femoral neck, you'd find fewer with the spine. If you put the two together, it's not additive because there's some people who are not low at either. But if you put in FRAX, you're going to get enough patients to make Goldilocks happy. What is FRAX? The National Osteoporosis Foundation changed its name. It's now the Bone Health Osteoporosis Foundation, BHOF. Don't know that they checked the internet when they made that change. When I looked, having been informed of the change, the first thing that came up was the Burlesque Hall of Fame. I don't know where you go. But their recommendations is that we should have a serious discussion about treatment to reduce fracture risk once it's high enough. And high enough would be a 10-year fracture risk of, hip fracture risk of 3% or above, or a 10-year major fracture risk of 20% or above. Calcium, vitamin D, exercise, important for bone health for everyone. How important? There are 200 different genes, at least 200, that contribute to bone health. And while a few of them, like collagen, osteogenesis imperfecta, may be critically important, most of the ones have minor contributions. Calcium absorption, calcium retention, vitamin D binding protein, vitamin D receptors, collagen production, estrogen receptors. So it's unlikely that any of these single factors is going to be dominant or critically important. Better safe than sorry is what I told myself when COVID shut things down. I realized how that applies to lots of decisions. And so better safe than sorry. Patients should try to get the right amount of calcium, try to be on target with vitamin D, try to do the right kind of physical activity, avoid smoking, reduce alcohol intake if that's excessive. That's probably not sufficient for patients who are at high risk of fracture. History physical exam, there's usually not a lot other than the bad habits that you might come up with. Lab-wise, I like to look at kidney function, calcium, vitamin D levels. Rarely do I find anything else. For men or women whose bone density is unusually low or a second test shows loss faster than expected, I like to do a 24-hour urine calcium and creatinine. If it's low with an optimal calcium intake and adequate vitamin D, that means they're not absorbing calcium adequately. If it's high, that means they're not retaining calcium adequately. And if either of those is a problem and we don't find it and fix it, they're probably not going to get the maximum benefit from whatever pharmacologic therapy. Bone biopsies helped us understand a fair amount about bone biology. Hard to actually get the procedure done, and even harder to find a place that will process it and give you useful information. And most of what we could learn from a bone biopsy, we can infer from bone turnover markers. Other tests that may be useful if there's a clue for thyroid disease or hypogonadism or Cushing's disease. What am I thinking of? Tryptase. Those are all things that are rare, but if you, in your history, in your physical, have some clue that something else might be going on, you should pursue that. This is a summary of a contentious discussion that our group had on testosterone. We felt that pharmacologic therapy, not testosterone, should be prescribed for men at high risk of fracture, whether testosterone is offered or not. And I'll show you data that tells us that it would be effective if testosterone is low and not corrected. Treatment with testosterone might be considered for men at high risk for fracture if they are not candidates for other agents, but we have a long list and can almost always find something. Or if they're not quite at a point where you feel strongly that fracture-reducing medication would be appropriate, and they have low testosterone, and they have symptoms of low testosterone, and they have an organic cause, then testosterone might help. I've gone through this with dozens of male patients, and when I start, I say we can give you testosterone, and if after 3 to 6 months you don't feel that you're better quality of life, we should stop. And the vast majority of them actually stop within 2 or 3 months. Now, I remember when I was a teenager, and there were times when I was adjusting to my changes in hormones that I was probably not the most pleasant person to be around. That was a gradual transition. And I've learned a lot from patients. When I started practice, it was not uncommon to prescribe estrogen for postmenopausal women for almost any reason you could think of. And I had a patient fuss at me because I'd given her a dose of estrogen that put her back in puberty, not gradually, but instantly. So if you're thinking about testosterone therapy for an older man, realize that if it's really low, that's probably been low for a while. And a gradual transition, I don't know whether 3 months or 6 months, may be better than just starting on a full replacement dose and let's raise your blood level up to where it is. How low? Less than 200. Morning sample, fasting sample, there's diurnal variation, there's pulsatile secretion, and so it's probably best if you have at least 2 values to drive you. And with the second one, worth doing LH-FSH prolactin to get some idea if it's central hypogonadism or primary gonadal failure. Low libido, erectile dysfunction would be the symptoms you're looking for, and reduce the dose or discontinue if there's side effects or clinical improvement. As being on the FDA's advisory committee for endocrine and metabolic drugs, I've learned some things about drug studies and drug approval. They say if you watch sausage being made, you probably wouldn't eat sausage. You probably feel the same way about some of these. The studies with drugs for testosterone replacement have very loose requirements that show that you're in the right range some of the time. So there have been concerns about cardiovascular safety with testosterone. I think that was one of the main concerns that we had 10 years ago. And when you read the studies and they talk about cardiovascular adverse events with testosterone, the most common one is edema. Was that really a cardiovascular effect? So this study was done to find out whether or not coronary disease was a problem for men given testosterone, and the conclusion is doesn't appear to be. Large study, older men, high risk for cardiovascular events, and no significant difference between the placebo group and the testosterone group. I was involved in a different study where we gave testosterone by injection to older men with lowish testosterone levels. One group had testosterone alone, one testosterone with finasteride, which blocks the conversion to dihydrotestosterone, and one group with placebo. Testosterone produced gains in bone density, and it was essentially the same whether or not you block that conversion. So it's dihydrotestosterone that has the anabolic effect on muscle. It's dihydrotestosterone that has an effect on prostate. In all 3 groups in that study, prostate volume and PSA levels went up over the course of the study, but they went up the least in the men who were getting testosterone plus finasteride, less than they did in the placebo group. This is a study with alendronate, the first bisphosphonate that was widely used for osteoporosis. It was approved for women in 1995, approved for men in 2000. And here you can see that regardless of the free testosterone level, that gains in bone density with treatment were similar. On my statement earlier, if testosterone is low, these drugs work. It turns out that in men, estradiol correlates better with bone density and fracture risk. Testosterone, not at all. Testosterone gets converted to estradiol, so there's something hormonally going on there that's important. And in our study, while we think of testosterone as anabolic, and it is in muscle, it worked more as an anti-resorptive for bone. So don't kid yourself when you're giving testosterone to a man for bone health that you're getting an anabolic effect on bone. It's through the conversion, not to dihydrotestosterone, but to estradiol. These are drugs that are out there, a complete list of anything and everything you might use. We're going to focus over here on the ones that are approved for men. There are 2 oral bisphosphonates, alendronate and risedronate. There's an intravenous bisphosphonate, zoledronate. There's a rank ligand inhibitor, denosumab, and the ones in lavender have no time limit. Medications for chronic diseases work for as long as they're taken, and so these can be initiated and continued for as long as needed. The ones in the shade of blue, teriparatide, abaloparatide, are anabolic agents. They stimulate bone formation through stimulating osteoblastic activity. And I think abaloparatide still has a 2-year time limit. Teriparatide was approved in 2002 with a 2-year time limit that was removed about 5 years ago. So there were concerns about osteosarcoma, that's a rat problem, but all the studies back then were limited to 18, 24 months, and so I don't know what would happen if you gave it longer. So in a primary care setting, the lavender drugs are the ones you might think of. I tell patients who are interested in risedronate, I'll let you in on a secret. Doctors don't like patients to call back, and it's a lot more expensive than the other oral alternative. So almost any patient that I see who says, send me in a prescription for risedronate, Actonel, calls back a week later and says, I didn't know how much this cost. Can we do something else? So my oral option, there are 2, but typically 1. The others are non-oral, so good choice for men who can't tolerate the oral medication, men if they have stomach problems, and that's where the oral bisphosphonate's absorbed, who might not absorb an oral medication, patients who just can't remember to take their oral medication, and the bisphosphonates have to be first thing in the morning, empty stomach, nothing but water, 30-minute wait. Anything else in the digestive system will block the absorption, and so there are patients whose morning routine is just so hectic they can't do that. So when should we treat? Well, before bone density came along, if somebody had a vertebral fracture, that's osteoporosis. If someone had a hip fracture, that's osteoporosis. And that takes precedence over any T-scores that are out there. Certainly for the small number of men who have reached that minus 2.5 or below, it's appropriate to have a serious discussion. And in clinical trials, we recruited men who were minus 2.5 or below, or even better if they'd already had a fracture. So that's where we know that this works. But the vast majority of men where this discussion would take place would be after you've done that FRAX calculation, that 10-year hip fracture risk, 3% or above, 10-year major fracture risk, 20% or above. How well are we doing with treatment? You might realize that in women we're not doing terribly well, but in men we're doing even worse. Part of that is the bad press that almost any medication gets. When I started practice, patients were happy if I could tell them what was wrong with them. And it was a bonus if I could tell them, and here's what we're going to do. And there were never any questions about side effects. Yes, doctor, thank you. Now it's most of the discussion, Dr. Google says bad things can happen if you do this. Bad things have been caused by these drugs. I say that's not what it says. They say bad things have been reported by people taking these drugs, but that doesn't mean the drug caused them. So it's really important, at least for me, to have some idea of where those concerns come from and from clinical trials or other data sources. How frequently did these things occur? What, if any, is the biological plausibility that would convince me this is truly a side effect? How serious is it? Could it happen to anybody? And what do we do when it does happen? I can't measure what doesn't happen. So we're all about preventing fractures, but we can measure bone density. Every now and then I'll come to the office and my nurse would say, well, your patient called and said she fell. She didn't break anything. She wants to thank you for that. Okay, I'll take credit. I don't know. But see the smile on the face of a patient when you say, well, you moved out of the osteoporosis range and into the osteopenia range. So these are early data with alendronate showing nice improvement in bone density over 2 years with oral alendronate. It was a daily dose then. The prescription you'd write today would be for a weekly 70 milligram. More gains at the spine than at the hip. So the scales are different. This goes up to about 8%. This goes up to just over 3%. And with all of our medications, they work better and faster in the spine. And you can see in the placebo group for men, spine bone density went up. I don't think that's the internal structure. I think that's more calcium wear and tear on the outside of the bone. Denosumab is the newest of the 4 on my list for long-term use, and you get better gains in bone density with that. Here over 12 months, you're getting up to about 6% in the spine and 2% in the hip. None of them work very well in the forearm, and I'm not sure we should be measuring that anyway. That's a longer story and a sideline. I think most of these medications work similarly in men and women. They've just been studied more extensively in women. In a 10-year study with denosumab, on average, spine bone density went up steadily, a little over 20% gain, and in the hip, it went up steadily, not as much, but just a little under 10% over 10 years. Life is not a bone density contest, and the drugs that I've told you about, I think, are equally good at reducing the risk of fracture. This is the study with the drug that's most recently approved for use in men. Abaloparatide is an analog of parathyroid hormone-related peptide. It's a daily injection that patients would give themselves, and over 12 months you see an 8% gain in the spine, 2 to 3% gain in the hip, and not much of a change in the forearm. There's only one study that shows a reduction in fractures for men. All the drugs have been shown to reduce spine fracture, and the ones I highlighted reduce the risk of hip fracture in postmenopausal women with osteoporosis. This study was large enough and long enough to show significant reductions in vertebral fractures at 24 months and an early reduction at 12 months. I was recruiting men for this osteoporosis study. Where do you get them? I bought advertisements in the Cincinnati Enquirer and placed them in the sports pages. Nobody called. We have a neighbor up the river in Kentucky. George Clooney grew up there, and his father, Nick Clooney, still lives there, and at the time had a radio show that had largely a male audience. So I talked to Nick Clooney, and we purchased some time on his show, and he interviewed me. Nobody called. I was getting discouraged and woke up with an idea. We sent letters to my female patients. Do you have a husband, brother, uncle, father? And all of a sudden, men started coming in. I don't know why I'm here. My wife told me to come. And so often the patients that you need to see, the male patients, are going to come to you because of somebody else pushing them. This is a little different story, and I probably misspoke, but these are men with early stage prostate cancer receiving androgen deprivation therapy. And this study, again, was large enough and long enough to show, even at as early as 12 months, a significant reduction in new vertebral fractures. Now, the study that I showed just before was men selected because they had osteoporosis. This study is men selected because they had early stage prostate cancer, not because they had osteoporosis. And you're looking over 3 years at a 3 or 4% new incidence of vertebral fractures with androgen deprivation therapy, lowering testosterone levels. So our urology folks are doing a pretty good job about countermeasures when they start this type of treatment. Our breast oncologists are not taking responsibility for the other side of aromatase inhibitor therapy to reduce the risk of recurrence in early stage breast cancer, but both those hormonal manipulations, while they may be good for the oncologist, are bad for us. So these drugs have utility there. Osteonecrosis of the jaw and atypical femur fractures, I don't have time to go into except to tell you that they frighten people, that they're rare, 1 in 10,000. They can happen to anyone. The jaw problem does appear to increase in frequency with longer-term bisphosphonate use unless there's an interruption in therapy. The unusual femur fractures don't seem to be related to the duration of treatment. The jaw problem is an issue with the intravenous bisphosphonate and the rank ligand inhibitor that are used in higher doses in oncology. Zoledronate is given to patients with multiple myeloma, where we give it once a year, they get it once a month. Denosumab is given to patients with metastatic solid tumors. We give it twice a year. Cancer patients get it monthly, and the dose they get is double. So we're looking at 10 to 12 times higher doses, and the jaw problem in that setting is 1 or 2% of patients. In the study with postmenopausal women with the IV bisphosphonate, Just over 7,000 patients over 3 years, there were 2 cases, and one was in the placebo group. In the 3-year study with denosumab, which was just under 8,000 patients, there were no cases. So not something that I would think to worry about. And in the denosumab study, there were no unusual thigh bone fractures, but that gets a lot of attention. So helpful that patients knew a little bit more about the low frequency and usually non-serious nature of those things. Probably not any different for men and women. Briefly to talk about the so-called anabolics, they seem to have less of an effect on the hip than they do in the spine. And while bone density doesn't necessarily tell us about fracture risk reduction, it's really about all we have to look at. And the problem with the studies with teriparatide, abaloparatide, and romosozumab is that they're short duration, relatively small, and there are not enough hip fractures for the statisticians to do any kind of analysis. So we're stuck with looking at what happens to the spine, and here you see 2 years of teriparatide, 2 years of abaloparatide, 1 year of romosozumab. So if you're in a hurry, you'll get there faster in the spine with romosozumab. A small study looked at teriparatide plus denosumab, so that's where you'll get the most for the spine. With teriparatide alone, you don't see much happening in the hip. With abaloparatide, which is a higher dose of a slightly different molecule, you get a better effect. With romosozumab, shorter and greater effect, or with the combination of teriparatide and denosumab, you get a greater hip effect. Many of the older men I see are low in the spine and not low in the hip, and any of these would be a good choice for them. But I have several male patients who are -5 in the spine, -5 in the hip, and I don't think teriparatide would be a good choice for them. Romosozumab is an antibody to sclerostin. It's a monthly injection that we give in the office. It has a 1-year duration followed by something else, and it's not approved for men. And so my options for men would be, let's do these two together. If insurance says no, plan B would be to use abaloparatide. And if insurance says no to that, then we'd use teriparatide. This came out in Nature Review as just a flow diagram of what came out of our task force. So you start with a fracture or low T-scores or a high fracture risk, and then you evaluate the patient, talk about lifestyle issues, measure bone density. Oops, no, I won't go back. So again, to remind you, if a man comes in with a forearm fracture and possible rib fractures, you should deal with that. I saw a friend recently as a patient for a follow-up visit. One of our mutual friends had a number of memorable sayings. One was, no one's life is a waste. You can always be used as a bad example. My friend Bob had rib fractures when he was in his 60s. Ignored them. He had a wrist fracture when he was in his mid-60s. He ignored it. He had another wrist fracture the other side a few years later. Ignored it. Then at 72, he was changing the diaper of his granddaughter on the living room floor, and when he stood up, he lost his balance. Baby's here. And Bob falls backward and has 4 compression fractures. He had an order from his doctor for a bone density test that sat on his desk in his office for 3 months before he did anything about that. But eventually he did teriparatide, and then we followed that with other medication. And that was 20 years ago. And he's not had any new fractures since. But Bob used to be about 4 inches taller than I am. And in the pictures now, Bob's the same height that I am. So those things can be avoided, or at least the risk reduced. Male or female database, don't think it matters a whole lot as long as you're doing the fracture risk calculation. That tool will use a female database, which based on geometry and other things makes sense. Testosterone, a minor part as far as managing this, maybe more in some settings. The evidence to reduce fracture risk for men is not strong, but there's no strong reason to believe that these drugs work that differently in men than they do in women, and there's robust evidence for a fracture reduction in women, and we now have the additional abaloparatide to add to the anabolic measurement. Whoop. So I thank you very much for your attention. I think there's a little time available for questions. Yes.
I was wondering what your comments are about Romo with cardiovascular disease.
Complicated issue. So when you have a surprising safety signal in a clinical trial, the first question would be biological plausibility. The second question is whether or not the magnitude is disturbing. And the third question that you probably would never answer, is this a real finding? Is there some other explanation, or is it just chance alone? So romosozumab in a phase 2 trial was studied for 2 years. Nothing bad showed up as far as side effects or safety concerns. The first large trial in postmenopausal women was over 7,200 women. It was a placebo-controlled trial for a year, and then denosumab for 2 years afterwards. There were no side effects and no safety signals. The incidence of MACE events, major adverse cardiac events, was 1% in the placebo group, 1% in the treatment group. Smaller study, 4,200 subjects, active control. So in an active control study, you can get older, higher risk patients. Alendronate was the active control. And cardiovascular events over the first year occurred in 1.1% of alendronate, 2% of romosozumab. Curious thing about the Kaplan-Meier curves for the MACE events in the placebo group, no, active group, alendronate group, there were none in the first 3 months. Then there were a few, and then there was another 3 months where there were none, and then it went up again. After the first years, there's no difference between groups, so it's all in that first year. That looks like it's probably random noise rather than a true signal. Another possibility is alendronate protects against cardiac disease. So the anomaly is not higher rates with romosozumab, but lower rates with alendronate. Biological plausibility, a lot's gone into trying to see their effect on lipids or vascular contractility or glucose, or nothing has come up that would implicate a mechanism of action that would account for that. So the warning, I think, better safe than sorry, says don't give this to a patient who has had a recent heart attack or stroke. There is a study in men, and it's my understanding that the data would be sufficient to get an indication to use that drug for men. And the numbers of cardiovascular events were small, but there were more in the treatment group than there were in the placebo group. So I asked the people at Amgen who have this drug, why haven't you gone for a male indication? And then I get a shrug, and we don't want to talk about it. Yes.
So you're recommending in asymptomatic men starting screening at age 70 if we can swing it, get it paid for, whatever, and then 50 to 69 if they have risk factors. Are there any other populations that you would deem at risk? For instance, it came up in clinic the other day, transplant patients not on glucocorticoids. Is that a group of folks that we should be worried about in screening, and specifically in men?
There's an old saying that if the only tool you have is a hammer, everything looks like a nail. So what I've been focusing on is identifying individuals at high risk for fracture. And I don't have the slide in this deck, but if you look at fracture risk before age 50, even the lowest bone density, the risk of fracture is low. The main benefit of the medications we've talked about is to reduce the risk of fracture. And so the target population would be patients whose risk is high enough. That would not include young people. But there may be a different role for bone density testing. So if you're a gastroenterologist and you have a lot of patients, young patients with inflammatory bowel disease or celiac disease or chronic liver disease, you may want to have some idea of where they are. Not necessarily that you do anything about it at that stage, but to get some idea of other markers of disease severity or progression. What are you going to do? There's studies in steroid-induced osteoporosis, and they include small numbers of premenopausal women. And in the postmenopausal women, these 12-month studies, the new vertebral fracture is about 20%, 1 in 5. But none of the premenopausal women had new vertebral fractures. So sort of the idea that if you're low but you're young, you're probably okay. Again, better safe than sorry comes in. So there's nothing that I've told you or in these guidelines that says you couldn't prescribe a bone-active agent for someone that you were worried about or who wanted to be proactive. There's some people who say, well, we should test everybody at age 50. Well, it'd probably be nice to know where they are, but if you're not going to do anything with it, the vast majority of patients, except create anxiety for some who've been told you have osteopenia and you need to worry about that, probably not a good trade-off there.
I guess a follow-up to his question would be, if you have those younger people who have these high-risk conditions, steroids, whatever, and they're not acutely going to fracture, are their rates higher later on? And would they be suppressed if we did treat them as they're younger?
Yeah, so I glossed over it on my list of all the drugs that are approved, but there was a column for prevention of postmenopausal osteoporosis. That never made any sense to me. The idea was you're 50 and you're minus 1.1. And so let's do something now to keep you from going down to minus 2.5. Well, how long would you need to do that? And how likely are patients to persist with that? I think that's somewhat of an issue with what we call prediabetes today. It's my understanding that the main risk of having prediabetes is to develop overt diabetes later on. And that most people with prediabetes do not develop overt diabetes later on. And unlike diabetes, it's not a risk factor for heart disease, stroke, amputation, blindness, or kidney disease. So you can give a drug to lower their blood sugar, but all you're doing is the blood sugar not providing any other benefits. The good news with these medications is we reduce the risk of fracture by 50 to 80% within 6 to 12 months of starting treatment. So it's not something you have to start 20 years in advance, like the patient with hypertension, where early detection and aggressive management is what we have to do because we can't offer them something as they approach the end stage of their disease.
Thank you for the lecture, Dr. Watts. I'm Emily and I'm one of the new endocrinologists on staff. I just have a quick question about osteoporosis or osteopenia in patients with on Lupron. So what would be your first line or first go-to drug for that?
Well, that's the androgen deprivation therapy. So the issue in men with early stage prostate cancer on androgen deprivation therapy, or women with early stage breast cancer on aromatase inhibitor, if they have a bone health issue that you need to deal with regardless, then I think you have longer-term treatment in mind. If their bones aren't too bad now, and what you're looking for is a countermeasure to minimize the negative effects on bone of treatment that might be stopped later on, then you have a different option. So denosumab doesn't build up a surplus. The offset is fairly rapid. It's not a good choice for a countermeasure because, I don't know, but if you're good, you'd probably be, I don't know whether you'd be worse or not for having done that. So if it's someone that we're only doing something to counteract that negative bone effect of a hormone deprivation therapy, a bisphosphonate would be my preferred choice. If it's someone where even if you stop your aromatase inhibitor, we're going to want to keep you on something for your bones because you're already -3, then denosumab would be another choice, one that you would continue even if the other option is stopped.
Thank you.
Thank you so much.